All right, thank you very much. So just before I start, I will say that I have no financial conflict of interest, but I do have a bit of an intellectual conflict of interest here. I've applied for a grant to study beta blockers in sepsis. So I'd like to start by giving a bit of the rationale of why we might try to use beta blockers in sepsis, then review the retrospective literature and circumstantial literature, talk about the Morelli study, which is the key piece of evidence in this, and then end on a note of where we might go from here. So I think everybody here in this room is here because we think sepsis is still a problem. The mortality from sepsis and septic shock remains high. This is a Kaplan-Meier curve from the process trial published in 2014. So after 15 years of pretty intense research into sepsis, we still have a 90-day mortality rate of 32%. So sepsis is a problem, and searching for new drugs and new treatments is important. We know that the heart is vulnerable in sepsis. So septic cardiomyopathy is remarkably common. That's in spite of a historical belief that sepsis is primarily a hyperdynamic state. Autopsies show that septic shock patients have extensive myocyte injury, contraction band necrosis, and interstitial edema in almost all patients. Clinically, both systolic and diastolic dysfunction are present. So sepsis is not just a hyperdynamic state, it is a disease which affects the heart directly. Now, why might beta blockade help in that scenario? Beta blockade can improve cardiac perfusion, decrease myocardial work. It can directly reduce cardiomyocyte dysfunction, especially if given beta-1 specific beta blockade. And the net effects can be monitored. So that's a very important distinction. We'd like to give a treatment where we can monitor the effect. The vasculature is vulnerable in sepsis, so not just the heart. The cellular basis for inflammation and vascular permeability in sepsis is really well defined. I won't go into it. The junctions between endothelial cells become disassembled. They respond to the inflammatory triggers, and that results in vascular leakage. This leakage can contribute to septic shock. The inflamed endothelium itself increases inflammation, systemic inflammation. And beta blockade may well affect that as well. So one of the hallmarks of sepsis is a disbalance between angiopoietin-1 and angiopoietin-2. An increase in angiopoietin-2 can lead to Tie2 antagonism and lead to a vicious cycle of vascular permeability through that mechanism. Beta blockade may specifically affect the Tie2 receptor and improve vascular leakage. Even if we don't look at the specific organ effects on the vasculature and the heart, persistent tachycardia in of itself may be a problem. So tachycardia in the initial stages of sepsis is often related to a low circulating volume, vascular leak. We have reflexive tachycardia to retain cardiac output. But in more than half of patients with septic shock, tachycardia persists after adequate fluid expansion. So that continued tachycardia in of itself is a sign of adrenergic overstimulation, not related to the volume status of the patient. And that tachycardia can be related to higher mortality. So this is some data from Sam Brown in Utah showing that tachycardia increases cardiac strain. So you see the heart rate on the x-axis, the heart rate on the x-axis, cardiac strain on the y-axis. And as the heart rate goes up, that is associated with worsening LV strain. That can lead to an increase actually be associated with an increase in mortality. So what is the hypothesis underlying treatment with beta blockers for septic shock? The cardiovascular dysfunction is central to the multi-organ dysfunction syndrome, that the usual treatment paradigm for sepsis and septic shock includes further adrenergic stimulation. So what's the first drug we give? Norepinephrine. What's the next drug we give? Adrenaline, dopamine, whatever your choice is, but all of those will lead to increased adrenergic stimulation. That safe, effective, and selective adrenergic antagonists may improve our treatment of septic shock, and that we can actually monitor these at the bedside. So increasing use of echocardiography allows us to monitor the effects of our beta blockade in an intelligent manner. Now, this concept is not new. It's been around. This is a paper from 1972 published in the Archives of Surgery. This was actually one of two papers published by some American surgeons where they treated patients with septic shock with propranolol, which was the beta blocker they had available at the time, and they very carefully measured the physiologic response. So this is one of 19 patients in this study. In this particular study, they measured arterial pressure, heart rate, central venous pressure, cardiac output, total peripheral resistance, which I guess is peripheral vascular resistance, PaO2, and urine output. They treated sepsis with some things we might not use today. So they gave antibiotics and fluids, but they also gave digitalis, caffeine, atropine. But importantly, they tried the use of propranolol, and that's what's relevant to our discussion. So propranolol was associated with a decrease in heart rate and an increase in blood pressure. The cardiac output decreased, but that was associated with the decrease in heart rate. The total peripheral resistance increased. So in spite of what you might expect from a beta blocker, in these septic patients, they actually saw an increase in the total peripheral resistance. And they speculated that the elevation was probably due to the microcirculatory effects of propranolol decreasing vasodilation at the same time as cardiac output was reduced due to the decrease in heart rate. And remarkably, for patients in the early 70s, they had an 80% survival rate in these patients treated with propranolol for septic shock. So early evidence. The use of beta blockade in sepsis really went out of favor, or was not, these papers weren't followed up. So we need to look at the more modern evidence, and this is mostly over the last 10 or 15 years. So first off, we know that increased doses of inotropes are associated with higher 90-day mortality. You know, not incredibly surprising. The sicker you are, the more likely you are to get inotropes, the more likely you are to die. But inotropes are independently related with increased mortality, and that includes in a propensity score adjusted analysis. So increasing use of inotropes, increasing adrenergic use is associated with increased mortality. That may be blocked by use of beta blockers. So this is a retrospective study out of Italy. About 11% of patients were treated with beta blockers prior to developing sepsis. And the 28-day mortality was substantially reduced in those patients. So pre-existing treatment with beta blockers seemed to improve mortality. That is, again, highly confounded data, since pre-use of beta blockers may just indicate that you have better medical treatment and are healthier to begin with. But very interesting retrospective data supporting the use of beta blockade in patients with sepsis. And this signal was consistent across all groups. So males, females, young, old, hypertensives, diabetics, prior CHF, everybody seemed to do better when they were treated with beta blockers prior to coming in. This is data, again, from Sam Brown's group looking at large cohorts of septic patients. They collected them, they analyzed, did those patients ever have bradycardia or not during their stay, and looked at the outcomes. So what they found this is two different ways of looking at it. This is the area under the curve, the extent of the bradycardia. And you can see the more time you were bradycardic, the less likely you were to die in these large cohorts of septic patients. And over here, the weighted mean of the heart rate, the lower the mean of the heart rate was, the less likely you were to die. So this suggests that patients who are spontaneously bradycardic do better, leading to the conclusion that perhaps if we induce bradycardia using beta-blockade, these patients will do better as well. There seemed to be a cutoff in this data around a heart rate of 80. So those under 80 did better, those over 80 did worse. Is beta-adrenergic blockade safe in sepsis? Well, there are several studies out there. These are all very small studies. And if we look at them together, there's about 100 and some odd patients in these studies. Some of them report mortality, some don't. Very difficult to draw a conclusion from these data. They all seem to indicate that it's feasible to deliver beta blockade to septic patients, but they don't really tell us whether that is useful. All told, 150 patients in these studies. So what is the efficacy? That shows us safety. We've seen preliminary data that it may or may not work, but the real trial that we can look at to study the efficacy is this trial from Italy by Morelli, published in JAMA in 2013. So they took septic patients, patients who had been optimized 24 hours prior to enrollment in the study. So they all had adequate volume resuscitation. They were all normotensive. They all had adequate oxygen delivery. And these patients were randomized, 154 patients randomized to get Esmolol or usual care. The Esmolol was titrated to a heart rate of between 80 and 95. These patients were, the groups were evenly matched. The patients had been well resuscitated, so they had received 4.5 liters of fluids in each group. That was equal between the groups. And the lactate was below 2 in both groups, indicating that they did have adequate fluid resuscitation prior to entry into the trial. So what did they show? They showed that Esmolol doses went up for the first 24 hours and then seemed to plateau. So this was a short-term treatment. They showed that increasing use of Esmolol actually was associated with a decreased use of norepinephrine. So that fear of causing hypotension with the Esmolol didn't pan out. The patients did not need higher doses of norepinephrine during the treatment. The Esmolol, as expected, since heart rate was the target, was associated with a decrease in the heart rate. The mean arterial pressure remained the same. The stroke volume increased, so the cardiac output seemed to be preserved because stroke volume increased while heart rate decreased. And here you can see the cardiac index stayed the same. So hemodynamically, a very good profile, showing again the safety and the ability to administer Esmolol in these very sick patients. And this was the punchline of the trial. The Esmolol group had a huge mortality benefit compared to the control group. And when you look at the numbers, the control group had a mortality in hospital of 90%. So that is, let's be honest, a higher mortality rate than you would expect to see in this cohort of well-resuscitated patients, leading you to wonder, what else was going on in these patients that you couldn't tell from the data. The intervention group mortality was much lower, but in fact, the intervention mortality rate was also relatively high compared to what you would expect in a cohort of patients this sick. So it makes you really pause and think, how much can we use this data going forward as a rationale for use of beta blockade in sepsis. And just to show that, this is a story we've seen before, I'd like to remind people of this study, the POISE study. In the POISE study, they randomized a huge number of patients, so 8,000 patients undergoing surgery to receive metoprolol or not to receive metoprolol. And this study was based on a lot of small studies that had appeared before, and those studies seemed to suggest that there was a mortality benefit to receiving beta-blockade prior to surgery, that it reduced non-fatal myocardial infarction, but they showed a small signal towards increased risk of stroke. And when the POISE results came out, it did indeed prove conclusively that beta-blockade reduced the incidence of myocardial infarction perioperatively, but it also showed that that signal for stroke was true. And when you balance those two out, actually POISE was associated with an increase in mortality. So plunging into a large beta-blockade trial based on insufficient evidence, I think we need to take this cautionary tale to heart and think a little more about who are the groups that may benefit from Esmolol in sepsis before we launch into a large trial. So what's next? You know, there's minimal data in the literature. I counted 304 patients who had been either treated or randomized to receive Esmolol. The mechanisms of benefit are a little unclear. So we follow heart rate, but is that really the right marker to follow when we're treating patients with Esmolol? Perhaps we should be targeting myocardial function rather than heart rate. The past experience is sobering, so I don't think we should rush into a large phase 3 ANZIC-style trial of everybody enrolled in the same treatment. And it's really difficult to support that type of trial right now. But what I do think we need to do is take the very promising evidence and signal and try to look harder at who may and may not benefit, what the mechanism of that benefit is, what the appropriate dose is, so that we can design a smart trial in the future. Thank you very much.